Hello everyone, this is Amir and this is the Hemostasis Week summary points for those who are not member of the Hematomorph but still planning for the part 1 exam. We had three scenarios for the Hemostasis Week. The first one was splenic vein thrombosis, part of splenic vein. The second one was type 3 von Willebrand disease, and the third one was related to von Willebrand pregnancy. So the first case was a young female with splenic vein thrombosis diagnosed on CT venogram, which was done for the abdominal pain. The question asked about different causes of splenic vein thrombosis and its causes, which the candidate mentioned very nicely as local causes, malignancy related, thrombophilia related, and others, and mention the investigations according to that. Remember, do not mention lupus anticoagulant in acute phase. You have to do lupus anticoagulant after 3 months of anticoagulation, and do not mention inherited thrombophilia testing now. You have to do the inherited thrombophilia screening after 3 months of anticoagulation if it is indicated as per BSH guidelines. Treatment wise, there are three options: lomocribate, heparin, Duox, and the warfarin. But the question said that this patient is planning for pregnancy, so better to give a safe choice, which is low molecular weight heparin. And also it depends on the cause as well. If the cause is likely antiphospholipid syndrome, then warfarin is a better choice. But before advising any anticoagulation, we always ask about patient platelet count, renal function test, liver function test, risk of bleeding, because the cause may be cirrhosis and this patient may have varices, so the patient is at risk of bleed as well. And patient choices are always respected. Then some of the candidate mentioned cytoreduction. No, yes, the patient platelet counts were high, but it does not mean that this is MPN. You need to have an evidence for MPN. MPN have their own diagnostic criteria for PV, for ET, for other MPNs. Then if the cause is PNH, or if the cause is any malignancy, you have to give the treatment of those conditions accordingly. Duration, lifelong if unprovoked. If it is related to solid organ cancer, 6 months, and then the review by the parent team. If it is MPN related or PNH related, again lifelong as well. Then the next part of the question was about perioperative plan. Patient was on rivaroxaban and the elective surgery was planned within the first 2 months. Better to delay it because this is a high risk period. The patient current clot can extend if there is interruption in anticoagulation, or a new clot can appear as well. So better to delay it. If not possible, then you have to check patient renal function. If they are fine, they are more than 50, the creatinine clearance is more than 50, then yes, you can stop rivaroxaban 48 hours before, and if it is less than 50, then 72-hour gap should be there. And then post procedure, because it was a hip replacement surgery, high risk bleeding risk procedure, better to give first prophylactic dose after 10 hours, and then the next dose should be therapeutic lomocribate heparin, and then convert back to um, rivaroxaban in the patient. The second question was about von Willebrand disease. They have given you investigations which shows that this is type 3 von Willebrand disease, and the patient presented with bleeding. Hemoglobin was very low, patient was symptomatic with anemia, and the question asks you about acute management. So acute management would include patient review by yourself, because you know that this is a hematology patient now. They have given you all the values, so you have to mention that I will review the patient by myself, and to make sure the patient is stabilized as well, IV access, vitals, arrange urgent blood transfusion for the patient. After consenting, I have to explain the available investigation to the patient, that we are dealing with type 3 von Willebrand disease, break the news in a breaking bad news fashion in presence of CNS, and then you have to mention Vocento as well. Not the 1 milligram concentrate only, the Vocento, which is a combination concentrate, because patient has low 1 milligram antigen and low factor 8 as well. So do not say that I will give 1 milligram concentrate, mention Vocento or the combination concentrate. If no relief or if there is a delay, then yes, you have to give Novo 7 to the patient. Novo 7 is available everywhere and is a bypassing agent. Then this patient was for dental extraction. So please do not mention DDAVP in this patient. This is a type 3 von Willebrand disease. DDAVP does not work in the type 3 von Willebrand disease. This is a suicide in the FRC path exam, both part 1 and part 2. Okay. So your aim is to keep the activity and factor 8 level above 50. Better to give this patient concentrate. This patient would already be on the placenta prophylaxis because this is type 3. Usually they are on the prophylaxis. So give this patient concentrate to make the levels above 50 and a day before the surgery, and then on the next day take bloods for the von Willebrand screen, and then go for the procedure. Again, give headings of pre-operative, intraoperative, and post-operative everywhere whenever you are planning any procedure for the patient. And for 2 to 3 days, keep this patient activity level above 50, factor 8 level above 50, along with tranexamic acid to continue. Usually, patient will be using it for a week in a minor procedure, and to follow up this patient again in hematology clinic, because this is your hemostasis patient, and we need to see how the patient is doing after the surgery. And then the third question was about von Willebrand pregnancy. The first question was about differential diagnosis. Some of the candidate mentioned hemophilia. Please do not mention hemophilia in female. It is very, very rare. There are special circumstances where you can expect hemophilia in the female, but it is not very, very common. Mention the common cause first and the least common cause at the bottom. The third part, or the last part, was about the antenatal management. If the question is specifically asking you antenatal management, mention only antenatal period. Do not mention postpartum issues, do not mention baby. If the question is asking you management of pregnancy, then yes, you have to mention preconception, antenatal, postpartum, and baby. But this question was specifically asking you antenatal management. So yes, this is a high bleeding risk pregnancy. Ideally, it should be managed in tertiary care center under an MDT of obstetrician, midwife, anesthetist, and hematologist. Okay, the patient should have all the information about this high risk pregnancy, risk to the mother, risk to the baby, for psychological support and information leaflets, and help her in decision making. Routine obstetric care for the pregnancy. No need to mention the scans. The target value for von Willebrand and factor 8 is about 50 if there is any procedure required in the antenatal period. The MDT has to decide a delivery plan for the patient. The indication of delivery, mode of delivery should be according to obstetric indication, and for the delivery, the factor 8 level and cough activity should be above 50. If it is less than this, DDEVP, if patient is responsive, along with tranexamic acid. If not, then you can give tranexamic, and you can give Vorcentro as well, okay, which is a combination factor. And non-uraxal anesthesia, you know that, and this much is enough. You can also mention that no NSAIDs, no IM injections, no instrumental delivery in your delivery plan, and it should be uploaded to the system or present in the patient paper document or file as well. The second part of the question was about counseling. You have to mention that this is a high risk pregnancy, what are the risks to the mother, what are the risks to the baby, what is the inheritance pattern, and the where this pregnancy will be managed, what are the risk of miscarriage or abortion or termination of pregnancy, and review of patient general health, review of patient medication. So these things will be included in the counseling section of the question. Thank you very much.